Hi everyone, welcome to my YouTube channel. So today's discussion point is rheumatoid arthritis. Okay, mainly the treatment options. So what is this rheumatoid arthritis? It is a chronic, long-lasting autoimmune disease that mostly affects the joints. Okay, so this rheumatoid arthritis occurs when the immune system. So we know that the immune system, what is their main function? Normally helps protect the body from infection and disease. So in this rheumatoid arthritis like conditions, what will happen? The immune system attacks its own tissues. Okay, so this is how RA like autoimmune diseases will occur. The disease causes pain, swelling, stiffness and loss of function in the joints. Now we will see what happens in rheumatoid arthritis or mainly the pathophysiology. So a combination of genes and exposure to environmental factors starts the development of rheumatoid arthritis. The immune system may be activated years before the symptoms appear. The start of the autoimmune process may happen in other areas of the body, but the impact of the immune malfunction typically settles in the joints. The immune cells cause inflammation in the inner lining of the joint, and this inner lining of the joints is known as synovium. Okay, synovium. So in rheumatoid arthritis, the inflammation mainly occurs in the or the immune cells cause inflammation in the inner lining of the joint called the synovium. This inflammation becomes chronic and the synovium thickens due to an increase of cells, production of proteins and other factors in the joint, which can ultimately lead to pain, redness and warmth, which all are the main symptoms of rheumatoid arthritis. As this RA progresses, the thickened and inflamed synovium pushes further into the joint and destroys the cartilage and bone within the joint. So what is cartilage? Cartilage acts as a shock absorber that protects our bones as well as the joints. As the joint capsule stretches, the forces cause changes within the joint structure. The surrounding muscles, ligaments and tendons that support and stabilize the joint become weak over time and do not work as well. This can lead to more pain and joint damage. So these all are the things what will happen in rheumatoid arthritis. Now let's see what all are the risk factors or who gets rheumatoid arthritis. So the first risk factor is age. Risk for developing rheumatoid arthritis increases with older age. Children and younger teenagers may be diagnosed with juvenile idiopathic arthritis, a condition related to rheumatoid arthritis. And the next factor is sex or gender. This rheumatoid arthritis is more common among women than men. Researchers think that reproductive and hormonal factors play a role in the development of the disease for some women. And the next one is family history and genetics. If a family member has rheumatoid arthritis, you may be more likely to develop the disease. There are several genetic factors that slightly increase the risk of getting RA. And the next one is smoking. Research shows that people who smoke over a long period of time are at an increased risk of getting rheumatoid arthritis. For people who continue to smoke, the disease may be more severe. Obesity. Some research shows that being obese may increase your risk for the disease as well as limit how much the disease can be improved. That is, obesity can affect the improvement of the disease as well. And the next condition is periodontitis or the gum disease may be associated with the developing rheumatoid arthritis. Lung diseases, that is diseases of the lungs and airways, may also be associated with the developing rheumatoid arthritis. So these all are the important or the main risk factors associated with the rheumatoid arthritis. Now let's learn about the treatment options. So the first and most important treatment option for rheumatoid arthritis is traditional disease modifying anti-rheumatic drugs, which can be denoted as DMARDs. Okay, these drugs are mainly used in the treatment of rheumatoid arthritis and have been shown to slow the course of the disease, induce remission and prevent further destruction of the joints and involved tissues. So the traditional DMARDs include methotrexate, hydroxychloroquine, leflunomide and sulfasalazine. Following the diagnosis of RA, these agents should be started as soon as possible to delay progression of the disease. Monotherapy may be initiated with any of the traditional DMARDs, although methotrexate is generally preferred. For patients with inadequate response to monotherapy, a combination of traditional DMARDs, that is a disease-modifying anti-rheumatic drugs, or use of a tumor necrosis factor alpha inhibitor or non-TNF biologic agent may be needed. NSAIDs or glucocorticoids can also be used for their anti-inflammatory actions. Okay, so the traditional disease-modifying anti-rheumatic drugs, that is the DMARDs, examples include methotrexate, hydroxychloroquine, leflunomide and sulfasalazine. So among these DMARDs, first we will see about methotrexate. Methotrexate is a folic acid antagonist. It inhibits cytokine production and purine nucleotide biosynthesis, leading to immunosuppressive and anti-inflammatory effects. So this methotrexate is a folic acid antagonist. It has got immunosuppressant properties as well as the anti-inflammatory effects. And this methotrexate is the mainstay of treatment in patients with rheumatoid arthritis. Response to methotrexate usually occurs within 3 to 6 weeks of starting the treatment. Other traditional DMARDs, TNF inhibitors or non-TNF biologic agents can be added to methotrexate if there is no or if there is inadequate response to monotherapy with this agent. Doses of methotrexate required for rheumatoid arthritis treatment are much lower than those needed in cancer chemotherapy and generally administered once weekly. Thereby, thereby we can minimize the adverse effect associated with the methotrexate. Then coming to the adverse effects includes the mucosal ulceration and nausea, then cytopenias, particularly leukopenia, cirrhosis of the liver and an acute pneumonia-like syndrome with chronic administration of methotrexate. So as we all know, the antidote for methotrexate is folic acid or leucovorin. Supplementation with folic acid may improve tolerability of methotrexate and reduce gastrointestinal and hepatic adverse effects. And one of the main toxicity associated with the methotrexate is hepatotoxicity. So periodic liver function test, complete blood counts, and monitoring for the signs of infection are recommended, and this methotrexate is contraindicated in pregnancy. Okay, so among the DMARDs, the next drug is hydroxychloroquine. It is used for early, mild rheumatoid arthritis and may be combined with methotrexate. Its mechanism of action in autoimmune disorders is unknown, and onset of effects takes about 6 weeks to 6 months. Hydroxychloroquine has less adverse effects on the liver and immune system compared to other DMARDs. Then the major toxicity associated with the hydroxychloroquine is ocular toxicity, including irreversible retinal damage and corneal deposits. Then CNS disturbances, gastrointestinal upset, and skin discoloration and eruptions. Now leflunomide. It is an immunomodulatory agent that preferentially causes cell arrest of the autoimmune lymphocytes through its action on dihydroorotate dehydrogenase. So after biotransformation, that means after metabolism, leflunomide becomes a reversible inhibitor of dihydroorotate dehydrogenase. This is an enzyme necessary for pyrimidine synthesis. And this leflunomide may be used as monotherapy in patients who have intolerance or contraindications to use of methotrexate in rheumatoid arthritis. Or it may be used in combination with methotrexate for patients with suboptimal response to methotrexate alone. The adverse effects include headache, diarrhea, nausea, weight loss, allergic reactions, including a flu-like syndrome, skin rash, alopecia, and hypokalemia. Then this leflunomide is hepatotoxic, so this drug is not recommended in patients with liver disease. And leflunomide is contraindicated in pregnancy. Monitoring parameters include signs of infection, complete blood count, electrolytes, and liver enzymes. Sulfasalazine, it belongs to sulfonamides. The sulfasalazine has recommendations for use similar to leflunomide in the treatment of rheumatoid arthritis. Its mechanism of action in treating RA is unclear. The onset of activity is about 1 to 3 months. And the adverse effects mainly include gastrointestinal, such as nausea, vomiting, anorexia, and leukopenia. Now, glucocorticoids. They are potent anti-inflammatory drugs, commonly used in patients with RA to provide symptomatic relief and bridge the time until other DMARDs become effective. Glucocorticoids should always be used at the lowest dose and for the shortest duration possible to avoid adverse effects associated with the long-term use. So in the previous slides, we have discussed about the DMARDs, which includes methotrexate, hydroxychloroquine, leflunomide, and sulfasalazine. Now the next category of drugs that can be used for the treatment of RA is biologic disease-modifying anti-rheumatic drugs. So this IL-1, that is interleukin-1 and tumor necrosis factor alpha, are pro-inflammatory cytokines involved in the pathogenesis of rheumatoid arthritis. When secreted by the synovial macrophages, interleukin-1 and TNF-alpha stimulate synovial cells to proliferate and synthesize collagenase. Okay, and this collagenase is responsible for degrading the cartilage. Cartilage is a shock absorber or act as a protective tissue for the bones as well as the joints, then stimulating bond resorption and inhibiting proteoglycan synthesis. Biologic DMARDs, which have been shown to decrease signs and symptoms of RA, reduce progression of structural damage and improve physical function. Clinical response can be seen with 2 weeks of therapy. TNF alpha inhibitors are usually employed in RA after a patient has inadequate response to traditional DMARDs. These agents may be used alone or in combination with traditional DMARDs. If a patient has failed monotherapy with one TNF alpha inhibitor, a traditional DMARD may be added, or therapy with a non-TNF biologic agent or a different TNF alpha inhibitor may be tried. These tumor necrosis factor alpha inhibitors should be used cautiously in those with heart failure, as they can cause and or worsen the pre-existing heart failure. An increased risk of lymphoma and other cancers has been observed with the use of TNF alpha inhibitors. Biologic disease modifying antirheumatic drugs or the biologic agents for the treatment of RA include TNF alpha inhibitors as well as the non-TNF biologic agents. TNF alpha inhibitors examples include adalimumab, certolizumab, etanercept, golimumab and infliximab. Non-TNF biologic agents include abatacept, rituximab and tocilizumab. Like TNF alpha inhibitors, non-TNF biologics are generally used in rheumatoid arthritis if a patient has an inadequate response to traditional DMARDs, and they may be used alone or in combination with the traditional disease-modifying anti-rheumatic drugs. If a patient has failed monotherapy with one non-TNF biologic agent, a trial of another non-TNF biologic with or without methotrexate is warranted. Patients receiving biologic DMARDs are at increased risk for infections such as tuberculosis, fungal opportunistic infections, and sepsis. TNF alpha inhibitors and non-TNF biologic agents should not be used together because of the increased risk of severe infections. Then reactivation of hepatitis B may occur with the use of these agents. TNF alpha inhibitors find use in a number of disorders such as ulcerative colitis and Crohn's disease, psoriasis, and ankylosing spondylitis. Then one more important point, live vaccinations should not be administered to patients taking any of the biologic DMARDs because as we already know, these biologic DMARDs mainly suppress our immunity. Okay, so if such patients receive live vaccinations, it can worsen the condition of the patient or may prone the patient to more severe kind of infections. Now let's see the drugs individually. First one is adalimumab. It is a recombinant monoclonal antibody that binds to TNF alpha and interferes with its activity by blocking interaction of TNF alpha with cell surface receptors. And this drug is administered subcutaneously weekly or every other week. And adverse reactions mainly include headache, nausea, agranulocytosis, rash, then injection site reactions and increased risk of infections. Next one is certolizumab. It is also a humanized antibody that neutralizes the biological actions of tumor necrosis factor alpha. Then it is usually given in a combined form with polyethylene glycol, that is it given as a pegylated form and administered every 2 weeks via subcutaneous injection. Adverse effects are almost similar to other TNF alpha inhibitors. Etanercept is a genetically engineered fusion protein that binds to TNF alpha, thereby blocking its interaction with cell surface TNF alpha receptors. The combination of etanercept and methotrexate is more effective than methotrexate or etanercept given alone in hindering the RA disease process, improving function and achieving remission. Okay, the combination of etanercept and methotrexate is more effective compared to individual therapy. And this drug is given subcutaneously once weekly and is generally well tolerated. Golimumab neutralizes the biological activity of TNF alpha by binding to it and blocking its interaction with cell surface receptors. Administered subcutaneously once a month in combination with methotrexate. And one important adverse effect is that golimumab may increase hepatic enzymes. And the next drug is infliximab. It is a chimeric monoclonal antibody composed of human and murine regions. The antibody binds specifically to human TNF alpha and inhibits binding with its specific receptors. And this one important point is that this agent is not indicated for monotherapy, as this leads to the development of anti-infliximab antibodies and reduced efficacy. So this infliximab should not be given as monotherapy, and this drug should be co-administered with methotrexate. And infliximab is administered as an IV infusion every 8 weeks. Then main adverse reactions include infusion-related reactions such as fever, chills, pruritus, and urticaria may occur. Now, abatacept, we know that lymphocytes are of two types. Okay, that is T lymphocytes as well as B lymphocytes. The T lymphocytes need two interactions to become activated. So the first one is the antigen presenting cell, mainly the macrophages or the B cells, must interact with the receptors on the T cell. And the second step is that the CD80, that is cluster of differentiation 80 bar CD86 protein on the antigen presenting cell must interact with the CD28 protein on the T cells. That is, these two interactions are needed to become for the T lymphocytes to become activated. So this abatacept is a recombinant fusion protein and co-stimulation modulator that competes with CD28 for binding on the CD80 bar CD86 protein, thereby preventing full T cell activation and reducing the inflammatory response. Okay, so this abatacept is mainly preventing the T cell activation and reducing the inflammatory response. This drug is administered as an IV infusion every 4 weeks. Common adverse effects include infusion-related reactions, headache, upper respiratory infections, and nausea. So the next one important drug is rituximab. In rheumatoid arthritis, B lymphocytes can perpetuate, means this B lymphocytes can continue the inflammatory process in the synovium by first one activating the T lymphocytes, producing autoantibodies and rheumatoid factor, and producing pro-inflammatory cytokines such as TNF alpha and interleukin 1. Rituximab is a genetically engineered chimeric murine or human monoclonal antibody directed against the CD20 antigen found on the surface of normal and malignant B lymphocytes. So this administration of rituximab results in depletion of the B cells. And this rituximab is administered as an IV infusion every 16 to 24 weeks. To reduce the severity of infusion reactions, methylprednisolone is administered 30 minutes prior to each infusion. Infusion reactions such as urticaria, hypotension, and angioedema are the most common complaints and typically occur during the first infusion. Tocilizumab and sarilumab. These drugs are recombinant monoclonal antibodies that bind to interleukin 6 receptors and inhibit the activity of pro-inflammatory cytokine interleukin 6. Both of these drugs are administered as a subcutaneous injection every 2 weeks. Tocilizumab may also be administered as an IV infusion every 4 weeks. Adverse reactions to tocilizumab include elevated liver function test, hyperlipidemia, neutropenia, hypertension, and infusion-related and injection site reactions. Okay, so the next category is Janus kinase inhibitor. Janus kinases are intracellular enzymes that modulate immune cell activity in response to the binding of inflammatory mediators to the cellular membrane. Tofacitinib is a synthetic small molecule that is an oral inhibitor of Janus kinase. So an example for Janus kinase inhibitor is tofacitinib. This drug is indicated for the treatment of moderate to severe established RA in patients who have had an inadequate response or intolerance to methotrexate. Metabolism of tofacitinib is mediated primarily by CYP3A4 and dosage adjustments may be required if the drug is taken with potent inhibitors or inducers of this isoenzyme. And one point to be noted is that hemoglobin concentrations must be greater than 9 gram per deciliter to start tofacitinib and must be monitored during therapy due to the risk of anemia. Likewise, lymphocyte and neutrophil counts should be checked prior to initiation of therapy and monitored during the treatment. Tofacitinib treatment may also increase the risk for new primary malignancy and opportunistic infections. Due to long-term safety concerns, tofacitinib is usually reserved for patients who have inadequate response or intolerance to other agents. Then one note is here, anakinra, azathioprine, cyclosporin, gold, and minocycline are other agents used infrequently in the treatment of rheumatoid arthritis due to their adverse effect profile or the availability of other agents with more proven efficacy. So we have completed the pathophysiology and the treatment options for rheumatoid arthritis. Thank you everyone for watching this video. Please like, share and subscribe. Have a nice day.